Hello everyone, this is a case of unsafe CSOM in a 15-year-old child. So we can see on microscopic examination there is a perforation. Previously there was a oral polyp which was removed 7 days prior surgery, and there is a small residual perforation along with that attic perforation. So post-oral approach we are adopting. So in unsafe CSOM, there is a bone eroding disease in the mastoid cavity, and this should be operated as early as possible because it can lead to some serious complication. So we are this is the post-auricular incision, and now we are doing the periosteal incision. So now posterior metotomy is being done. So surgery is undergoing under general anesthesia. This is the child is having ear discharge since 10 years. So after lifting the temporometer flap, we are doing the drilling in the outer attic wall, and this is the inside out approach. We are removing the portion of the superior and posterior deep piedestal wall. So atticotomy is being done. So So this is now we can see the glimpse of the cholesteatoma tissue, and here these are the eroded ossicles. This is the incus and the malleus, and the part of the incus is being removed, and this is the cholesteatoma which is visualized and it is seen going inside the mastoid antrum. So we will follow the cholesteatoma posteriorly by drilling the posterior superior canal wall. So this is being done in stepwise manner. So so this seems to be an extensive cholesteatoma, and the posterior aspect of cholesteatoma is it seems it is reaching up to the tip of the mastoid cavity, mastoid tip. So we need to drill out the bone as much as possible posteriorly to reach the posterior limit of cholesteatoma inside the mastoid antrum. So this is the cholesteatoma. Now we are drilling at the McEwan's triangle, and we are removing the bone so that the posterior limit of the cholesteatoma can be reached, as it is the extensive cholesteatoma. So inside out approach, it saves time, and it has less chances of injury to the dura and the sinus. It is helpful in cases of sclerotic mastoid and in cases of low lying dura and forward lying sinus. So this is the cholesteatoma which can be seen going posteriorly in the mastoid antrum. So we are drilling, and we are just trying to find out the posterior limit of the cholesteatoma. Now the cholesteatoma is gently lifted and it is being dissected anteriorly. Now the posterior limit of cholesteatoma has been reached and we are separating the cholesteatoma from posteriorly, and now we are following it anteriorly into the epitympanum. So this, this is the epitympanic part of the cholesteatoma. At the same time, we are lowering the facial ridge. So this is the portion of the middle ear. We can see the facial canal. So this is the cholesteatoma from the sinus tympani area, which is being removed. Now we'll lower the facial ridge. So this is our we will further lower the facial ridge, and now we will harvest the temporalis fascia. So this is a piece of temporalis fascia which will be used later on to reconstruct the tympanic membrane. Now we will do the metoplasty, making the incision in the incisura terminalis. Then a wide metoplasty should be done. Here we remove the part of floor cartilage and also the part of conchal cartilage. So this is the part of the floor cartilage which will be removed, and this will be later used for ossiculoplasty. So now we are removing the part of conchal cartilage. So our final step is now the tympanic membrane reconstruction and ossiculoplasty. Here all ossicles are eroded, only the stapes superstructure is present, so type 3 tympanoplasty will be done. This is the floor cartilage which is being used for type 3 tympanoplasty. It will be put over the stapes superstructure. This is the final picture. Thanks for watching.